Well, greetings. Thank you so much for tuning in to the Advancing the Kingdom podcast. I am your host, Matt Tillery. I greatly appreciate you tonight. Just really thank God for you and thank you for logging in. And I'm doing a couple of things at one time, but I can do it. Listen, thank you so much for just coming in tonight. And if you're on Facebook, go ahead and hit the share button. I would greatly appreciate it. And if you're over on YouTube, go ahead and share, subscribe to the ML Tillery Outreach. I would be so grateful for that as well. Listen, tonight is the fourth Monday night, and of course, on the fourth Monday night, we have none other than Dr. Denise Gooch, Keeping It Real with Dr. Gooch. Thank you so much for coming on tonight. As always, you certainly bring a plethora of information and knowledge, and we're grateful to have you on the podcast each fourth Monday night of the month. We really appreciate you.
Well, thank you so much. It's an honor and privilege to be here. And I know we're going to have a great evening, just like we have in the past, sharing some information, answering questions. And I hope everyone gets something out of this. Amen. I actually look forward to this.
Greatly. Listen, if you have questions tonight, you can put them in the Facebook chat comment section. And also, if you're over on YouTube, you can put it in the comment section there as well. We have someone monitoring those pages, and we will be glad to get your question over to Dr. Gooch. Listen, last month, Dr. Gooch, we started a conversation around prostate cancer and, of course, ED, erectile dysfunction, which is the inability to get or maintain an erection. And you talked about three things. I'm a good student, so you talked about the brain, nerves, and blood flow working together to get an erection. Talk about that a little before we dive into some more things. You talked about the brain, the blood, and blood flow. I was getting a lot of questions about that after that podcast.
Well, I'm glad you remember those three things, because for every person to remember, it's kind of like what your friends say. An erection for a man starts in the brain. It actually starts there. Okay. So he either something he sees, something he thinks, or from some type of physical stimulation. That's how the whole arousal process starts. So it starts in the brain though. So once that brain releases that signal, all right, and that signal travels down to a man's penis and basically starts him getting an erection. It relaxes the blood vessels, and so he can actually have increased blood flow in that area, which causes him to have an erection. But of course, remember I told you those three things: the brain, right, then it releases the nerve signal, then the blood supply. So that's why those three things are important for an erection. So when a man has problems with an erection, whether it's through, like sometimes men have neurologic problems like multiple sclerosis, or he's had a stroke, he would have problems getting an erection. If he has issues with blood flow, either because cardiovascular disease, high blood pressure, or even diabetes, which could impact his ability to have an erection. So anytime you have anything that interferes with those three processes, a man can have erectile dysfunction.
Wow. Why do you think it is so difficult for men to talk about ED?
That is a good question. I guess it's a very sensitive subject.
Yeah.
And it's sometimes I think about this when I see a man and I'm seeing them in consultation, because it's kind of like when a woman sees an OBGYN, we don't feel uncomfortable asking them about sexual dysfunction, vaginal issues, things like that. But for men, and I'm not sure, hopefully every man realizes, we are well trained on sex and sexual functions, because that's part of your body and your functions too.
Right.
So every person, whether it's male or female, should feel comfortable discussing sex, sexual functions, lack of sexual functions, lack of desire, decreased desire. All of those things are something that every person should feel comfortable discussing with their doctor, because your doctor is trained in that. So it's not like you're going, and trust me, you go to your doctor, especially if you go to an oncologist or urologist, you're probably the 10th person who's asked them that question that day. So you are not going to ask them anything they haven't heard. And they're not going to be surprised. They're not going to be shocked. As a matter of fact, one of the things I tell patients when they come and see me and they feel comfortable and they start saying, "Can I ask you something?" And I make it very clear, you can ask me anything.
Right.
That there is no, "Oh, you just don't ask that." We have a barrier that we have to restrict what you can ask.
Right.
No, we're well trained in all facets of human anatomy and human response and everything related to the human body. So everyone should feel comfortable. That's not something, and I'll be honest with you, a lot of people are raised in ways that maybe they feel nervous or uncomfortable discussing certain things.
Right.
And sometimes when I talk to some of my friends, even as adults, they kind of talk like children. But I think that's in a lot of times the parents' way of trying to protect you, because I think if they believe, the parents, I think, believe that if they talk to you too openly, that you'll get too interested and you may try to do too much.
Right.
But also by imposing their own maybe biases and their effort to not talk about certain things, then you think that's something you shouldn't talk about, and that's something naughty, and only bad boys do certain things,
Right.
and only
Right.
bad girls are interested in certain things. I mean,
Right.
I know everybody's sitting there, but that's unfortunate because people's own hangups can project them onto other people, and that's really unfortunate because as an adult, you should be able to explore and enjoy whatever, within reason, of course,
Right. Right.
as long as everything's legal. That's something that you're interested in. The only thing that restricts you is maybe opportunity, but as
Right.
long as everything's legal, that's not something that should be hidden and locked behind closed doors and only done in the dark or something like that.
Right. Wow. What are some of the reasons that, once you getting your treatment for prostate cancer, whatever treatment that you're getting, what happens to the prostate oftentimes that causes the erectile dysfunction? Or does anything happens in terms of, does the radiation affects the nerves and all of that stuff?
The erectile dysfunction.
Or surgery?
Right. Well, the prostate, right. Right, exactly. So the prostate is part of the man's reproductive system, both in his ability to not so much have sex, but in the ejaculatory process. When he's ready to ejaculate, it provides the liquid, the semen, for the ejaculate. All right. So the thing about it is, if a man has surgery, this is why quite a few men, when they have surgery for prostate cancer, as you're talking about, that while they're doing the surgery, all those nerves that are supplying, because remember, you got the bladder, you got the prostate, which is at the base of the bladder, and the prostate, and all that's connected to the penis, obviously, all that's
Right.
all down in there. And so when they're doing surgery, the surgeon, the urologist, can potentially either damage some of those nerves. That's why they talk about the nerve sparing prostatectomy. But even still, when they're not damaging the nerves, they can kind of scrape against the nerve and maybe injure the nerve in the process of doing the surgery.
Right.
So that's why, even when a lot of times, and I know people are probably listening to this, think about, they talk to the urologist and they'll tell them, "Oh yeah, we can do the surgery and you'll still be able to have an erection." The problem is less than 50% of men, after they have surgery, even the nerve sparing is about 50 to 60, but for the non-nerve sparing, when they have surgery and they really have to be aggressive to get that prostate out, remember, it's all kind of socked in there together.
Right.
The risk of those nerves being affected is quite high, and only about 30% of men are still able to have an erection after the surgery. The quoted amount is about 35%.
Maybe that answers the question that was just asked. Can you still have sex if you get your prostate removed?
You can technically, like I said, what you need is the brain, the nerve, and the blood supply. So
Right.
the blood and the brain still working is that nerve supply that's been interfered with a little bit. But that's one of the things that I talk to people about. And one of the reasons I'm glad we're discussing this is that I recommend for all men, whether they're getting the surgery or the radiation, most people who've heard me talk know that I tell them this, for a man to get started on either Cialis or Viagra before they undergo these procedures, because they actually have studies that have shown that if a man takes Cialis before undergoing the radical prostatectomy, before, not after, but
Right.
before he undergoes it, he's able to sustain his own ability to have an erection after the surgery.
Right.
And the same thing has been shown for not as many strong studies, but there are some smaller studies out of New York that show that the same thing happens if a man takes Viagra before the radiation. And that's something that most people who've heard me talk know that every man that I treat that's healthy, that I treat their pelvis for any reason, whether it's for prostate, any reason I'm radiating a man's pelvis, usually I start them on Cialis. That's my preferred medication. It has fewer side effects. It doesn't interact with as many medications. And every man that I've prescribed it to, let's just say when they come back to see me 6 months, a year, they're very happy that they're on it because they haven't had any problems after the fact.
Wow. So here's a question. So let me see, how can I ask this question here? So the question is, statement, and then the question. The statement is, I am fearful of going to the doctor for my prostate because I am afraid that if they find cancer, prostate there, cancer there, that I will be unable to satisfy my wife. How would you respond to that?
I would respond that the person who put that question in is very courageous. And I want to thank you for making that statement and asking that question. You are very courageous, because I guarantee you, every man who's listening to this podcast is thinking the exact same thing.
Right. Exactly.
So
Appreciate it. Yes, you're right.
exactly. So I just want to applaud you for your courage of saying that. Because as anyone, I've given talks about this for over 5 years. And when I first, and you've heard me talk about this before, they tell us part of our training that the main reason men don't want to undergo screening and treatment for prostate cancer because they're afraid of the digital rectal exam. You've all heard that. Right. I began to suspect that wasn't the truth. Right. And then they actually, for a lot of people, they've eliminated that, saying, okay, so we'll eliminate the digital rectal exam. Then men still didn't want to get screened for it. So that's when I would actually tell my colleagues, because my colleagues were still believing that. I said, no, the reason men don't want to be screened for prostate cancer because they don't want the risk of erectile dysfunction.
Right.
And everyone seemed surprised when I said that. I gave a talk in Atlanta one time, and I made that statement that the number one reason men do not want to be screened for prostate cancer is because of the risk of erectile dysfunction. It's real.
Right.
But it's not as bad as it sounds. And literally, some of the women who were in the audience, especially some of the women who had lost their spouses to prostate cancer, either because, quote unquote, they were diagnosed late. Now, you can be diagnosed late, but most men, if they know their PSA is high or whatever, or the doctors are saying, I need to get this evaluated, we need to get you treated, but they don't want to risk the risk of erectile dysfunction. And I could see the look on the women's faces like, wait a minute, you mean I lost my husband, I lost my father, I lost my brother because he didn't want to have erectile dysfunction?
Right.
Yes, unfortunately. So that's one of the reasons why I think this podcast is so important, because, as I just said, if a man uses the Cialis or the Viagra before any treatment, all right, 75, and I have data to support this, 75% of men, no matter what your treatment is, will be able to retain their ability to have an erection. All right. Now
Right.
that's
Right.
the medication. Remember, there are other
Right.
types of treatments. I think you had someone on the show that had a penile implant. So
That's
there are
correct.
other things in addition to the medication, but the medication is extremely effective.
Yeah.
And that's actually, like you said, that's my first line. I start there first. There are other types of treatments. There are little suppositories. I talked about this the last time I was on. That they're very small. I've actually thought about that, and men look at me like, "What are you talking about?" But they're very, very small. They're smaller than a piece of like a rice kernel. They're very, very teeny. And what a man does, he just inserts it into the head of his penis, and what that does, it dilates the blood vessels, so it pulls the blood into his penis. And then, depending on the amount of maybe this lack of erection, trying to think of a good politically correct way of saying that, he can. There's something called a penile ring. All right, so he can put the ring at the base of his penis to maintain that blood flow, so he can sustain an erection. Okay. There's also what they call penile pumps, which is almost like a bicycle pump. So a man would put basically the suction part over the penis, and then it draws out the air on the suction pump. It pulls the blood into the penis. And then a man can put the penile ring on that we just talked about. There are also injections, okay? And the injections work similar to the medications. They're all kind of the same formula, the same chemical formula. And what it does similar, it causes blood flow, it increases blood flow, it works very fast, and it will actually increase the blood flow to the penis. So what I don't want is for a man to basically lose his life because unfortunately prostate cancer, as you know, is the number one diagnosed cancer in men. It's the
Right.
number two cause of death for men, which unfortunately disproportionately affects African American men. So, like, the person who asked that question is extremely brave, and I just want everyone who's listening to this is like, it's an extremely brave question. It's an extremely important question. But the most important question, as I said, it's when I see the looks of the people in the audience, the wives, the surviving girlfriends, the mothers. I actually have a patient right now who's in his 40s who was
Wow.
just diagnosed, and he was completely blown away. So
Wow.
anyone who they've lost a family member that they love, but in the back of their mind, when I suddenly say that, they're thinking, so you mean I lost my husband, my brother, my father because of the risk of erectile dysfunction? You see, as a
Right.
woman, you can't process that, but that's why that question was so important, because yes, that's the reason they didn't get treated.
Wow. Yeah, I remember when I was the urologist. He was coming in the room this evening, and he was like, I could tell something was wrong with him. So I'm like, I'm becoming a counselor now for him, and he said that one of his patients committed suicide because he found out that he had prostate cancer, and he said
Mhm.
this man could have lived. I mean, but just to think of something like that, and you see
Mhm.
so much of that stuff, right? Uh,
Mhm.
so wow, I was thinking about that as you was talking. So
Yeah.
yes, it's crazy. So does the type of prostate cancer and play a role in the severity of ED?
That's a good question. So the more advanced the prostate cancer is, okay. So there's different lobes of the prostate. So if a man only has a small amount, quote unquote, so when they do biopsy cores, so let's say only two of 12 biopsy cores have prostate cancer in them. So that is correct. There's more than likely he's less likely to have the erectile dysfunction. Only because just the volumetrics of it, the amount of bad cells that are kind of pushing on his prostate and maybe putting some compression on his urethra and kind of backing up along his penis, and of course affecting the blood supply. So when he has maybe a small amount, quote unquote, he may not notice as much erectile dysfunction. The problem is if there's some in there, it's unless it's treated, it may kind of that's why I'm not a big fan of active surveillance, as most people know.
Right.
Because if it's there, it's going to keep doing something. It may not jump off in the next month or two, but it's going to do something at some point.
Right.
So that's why people being aware of, I don't want to treat this now. Maybe, yeah, you may want to treat it later, but then it may be more advanced. All right. As everyone knows, that the cure rate of prostate cancer has the highest cure rate of any cancer. I tell this to everybody everywhere I go. The highest cure rate of any cancer I treat. There's no other cancer that I treat that has as high a cure rate as prostate cancer does.
Wow.
But yet it's the number 2 cause of death. So
yeah, that doesn't make sense, does it?
No, it doesn't. It doesn't. It's especially since there are treatments, very effective treatments, that totally will make a man still be able to function as a man. He can still have his sex life. He can still enjoy life. But most importantly, he'll still be here to enjoy life, because I've talked to some of my urology colleagues, and they will even say, being able to have an erection isn't going to help you a whole lot in your casket. It just isn't.
Right. So getting screened, which it goes back to getting screened, because if you're getting screened, maybe you could catch something in time to deal with it, so before it gets too progressive in your body.
Absolutely. And as we already said, unfortunately, African American men are 2.5 times more likely to be diagnosed with prostate cancer. So one of the reasons why even sometimes your primary care doctor may even say, well, you don't need to be screened. You're not, just the fact you're an African American man puts you at high risk. And that's something I've actually discussed when I've been at meetings. When people make those kind of statements, I say, what you need to do is go back and actually read the whole article in the NCCN guidelines, not just the summary, because they will state for certain men and certain groups, when they quote all of those numbers, those are average risk men. African American men, by virtue of the fact that they're African American, makes you basically, they're in the category of high risk. So that's a totally different category. So African American men don't fit into those usual guidelines. And we don't recommend that an African American man wait to the age of 50. That sometimes some people want to follow. As I just told you, I have someone who's just referred to me. He's only 41. He just turned 41. And he is completely blown away, but he actually is handling it very well. I'm quite impressed with him. But so we're talking, so African American men, their actual recommendation, if you really look at it, is that African American men, since their risk and their incidence is higher, should start screening at the age of 45. And if there is a family history of it, blood relatives, we call first degree relatives, brother, father, they really should start getting screened at age 40.
Wow.
Like I said, my patient's just 41, and he did not have a family history. I found interesting. So I even asked him what made him do the screening. He said he just wanted to do the entire profile on him, and he had no family history.
Wow.
So yeah, but it's really, I can't emphasize enough. As I said, whenever anyone tells you it's not necessary, it has the highest cure rate, 95%. I say this to everybody, and they look at me strange. 95% 5-year survival. There is no, as I tell, really 99%. I look at people and say, you don't have a 99% chance of making it to your car.
Right, exactly.
What else has that higher cure rate? It's nothing else. It's nothing that we treat that has that higher cure rate.
Wow. Yeah, I have a friend. His PSA was 11, and it was still going up. It was still increasing. And the doctor was telling him, we're just going to do the active surveillance. And I had a long talk with him. And long story short, he's getting the proton therapy now. So grateful for that.
Now you're a good advocate for proton therapy. Now we can switch the microphone over to you.
Yeah. So, but yeah, I totally agree. I don't. Active surveillance wasn't for me, because my thing is, I mean, I didn't know a lot about prostate cancer and all that stuff, but I did I had common sense to know that if it stayed in the body, it was still doing something, right?
Mhm. That's
So
right.
yeah, so I wanted to. Yeah, so that there are a wide range of treatments for ED, including medications, surgeries, and devices. Which one, I guess, is not one that works over the other, because the last guy that I had, he tried all of them in his last method, which you talked about the last time you were on, where it was the pump, the penile pump.
Yeah. The penile pump or the implant.
I mean, excuse me, an implant. Yes.
Yeah, yeah. Actually, when you look at, it's kind of a series of treatment trees. So the initial recommendation is to try the pills, the oral medications,
Right.
because remember I said it works for 75% of people. So
Right.
that's pretty good.
Yeah, that's it. That's a good number.
That's a good number.
Yeah.
So the medication is the first line of defense, I guess you could say. But as I said, what I do, I start men on it before they start treatment. I don't wait until men have treatment. And I tell men that if you do have surgery, ask your urologist to start you on it. They don't care. They'll be like, oh yeah, okay. And they'll just kind of, they won't
Right.
even blink.
Right.
Why they don't do it preemptively, I don't know.
Right.
I do it preemptively for any man who gets radiation. So that's something I recommend. Anybody who's listening to this, if you're thinking about following up, ask whether it's your radiation oncologist, it's your surgeon. Tell them you heard this doctor that said if you start the Cialis or Viagra that you won't have the erectile dysfunction. Trust me, they won't even blink. They'll be like, yeah, okay. So,
So no
if I
problem.
don't do anything else, I want to get that message across before you undergo the treatment.
Right. Right.
All
So
right?
when you get the news of prostate cancer or any type of cancer, you're gonna get that stress feeling. Is that a contributor to ED as well? Having
Well,
prostate
as
cancer,
we
and
all
then
know, I mean, right. Of
yeah,
course, stress, even without prostate cancer.
right,
We
exactly,
just talked about ED, erectile dysfunction. For any man, it can be physical or physiologic, whether it's
right,
stress, um, work-related issues, relationship-related issues. Maybe he's not sleeping well. So anything that kind of throws your body out of whack can basically cause a man to have episodes of ED. We talked about before having diabetes, and you probably have talked to people, read articles. Any health issue, remember we were talking about
right,
nerve, blood, and brain supply. Any health issues, diabetes, high blood pressure, and being overweight, unfortunately. Basically, that's because when a man has a lot of adipose tissue that can be converted into estrogen, a man needs testosterone in order for his male urge and the male drive. So that it all feeds into the whole erection and nerve supply. So anything that can impact that you've all heard of, that low T, you see these commercials like low T, to increase your
right,
testosterone, things like that. And that we're just talking about men in general, men's health. So I
right,
found that interesting. So I said, okay, so what's low T? So as you know, most men probably know, you can actually have your testosterone levels checked. Just giving you general information.
right,
And the average, actually I printed it up. I thought it was interesting. The level of your testosterone is usually from 450 to 600 nanograms per ml for a quote unquote normal male. So whenever it drops below 300, that's what's called low T.
When
So
it
in
drops
case
below three, you said 300.
300, yeah, the normal is 450 to 600.
Okay,
Yeah, nanograms per ml. So, and it's just a blood test.
right. Wow.
Yeah,
So
I just thought that was interesting.
yeah, it was. It is. So I have one more question. What is a Gleason score?
Gleason, that's an excellent question. When we just talked about if a man undergoes the workup and then he has a biopsy. So the Gleason's is a scoring system. That's why it's called a Gleason score. That when the cells are looked at under the biopsy, and this is something I actually have pictures that I show. I give lectures to medical students and residents at the University of Maryland. I actually showed them a slide of what the normal prostate cells look like. So they're biopsying the prostate, and there's a way that the cells look. They're just kind of little nuclei, little, they're little things in the cell that look all normal, just kind of like a little, I don't know, like a little Christmas tree, just, doing their function.
Right.
But as they become more abnormal, they still have some normal cells in there, but then you can start seeing the abnormal cells. They're changing. So when biopsy is performed and they look at the Gleason score, what it is depending on, like, if there are 12 biopsy cores, because when they do put the needle in there, they're doing cores in each section of the prostate. They compare those cells in each core. So let's say 70% of the cells look normal and 30% look abnormal. Okay, so that would get a Gleason score of 3. So then you look at another biopsy core and 40% of those cells look abnormal. That would get a Gleason score of 4. So we add those. So, and this is something else I teach my medical students. 3 plus 4 is not the same as 4 plus 3, even though both of them mean 7. Right. But a 4 plus 3 means the predominant cells in the biopsy cores was a 4. The first number is the most dominant cell type. The second number is the least dominant. So a 4 plus 3 means the most dominant cell type was the more aggressive 4. A 3 plus 4 means the most dominant type was the 3, the less aggressive cells. So the reason that's concerning is because if you have a 4 plus 3, you probably have heard a thing called upgrading, which right. means that when men go to surgery, that they actually, when they take out the prostate, they thought and I'm sure people have told you this, they thought it was just a Gleason 7, but then when they take them to surgery, they realize they had a Gleason 8 because some of those 4s were already in there. It's just where they did the biopsy.
Right.
So that's why that's actually what's called grade group 3, once it's actually a 4 plus 3 versus a 3 plus 4.
Wow.
So yeah, the Gleason score is an important. So the main things you want to know is the Gleason score, because that gives you a lot of information about how aggressive that tumor is, as well as, of course, the PSA level. PSA stands for prostate specific antigen, and that's an important blood test, because what it's showing you is, that's why when they do that active surveillance, which of course everybody knows I don't like, but if you must do it, they need to do it on a regular basis, which I don't like it, but if a person's insisting on do it, at least, as a matter of fact, the American Cancer Society said if you have an elevated PSA, let's say it's 6, all right, now, anything up to 4, quote unquote, is considered elevated. The truth of the matter, though, is at least 15% of men have a PSA of 2.5. They actually, if they biopsy them, have prostate cancer. So that 4 isn't the magic number. That's usually what they quote. But anyway, meantime, men told me. So then 2 years later, when it gets checked again, or a year later when it gets checked again, and I think you can understand this.
Right.
Then it's either now it's a 10 or it's a 12 or it's double. Like you said, it's not sitting there, drinking coffee. It's doing something. And unfortunately, almost always, especially for African American men, that's why I get a little angry when people start quoting data that they have for some of the studies, the international studies, because oftentimes these are European men. They don't tend to have as many high-grade aggressive prostate cancers as African American, and not just African American men of African descent. So it's actually, prostate cancer is very prevalent too, unfortunately, in men from Africa as well as from the Caribbean too. Right. So that's something else that a lot of people don't realize. So it's men of African descent that have the more high-grade aggressive prostate cancer. So that's why, as I said, I don't believe in active surveillance for African or African American men. But definitely, if you start seeing it climbing, that's basically, like I said, wake up and smell the coffee. It's telling you something.
Right. So a lot of those studies are not done with us, basically.
Exactly. They may have a representation, like they say, oh, this was studied in 2,000 men. How many of them were African American? Okay.
Right.
So they'll have 2,000 men and 1,800 of them were European. and almost always only a small percentage, like less than 5%, were actually African American men.
Right.
And so it's like, if you look at what you always got to remember about data is that they kind of have a selective way that they look at data. So, and this is something I teach my students. When you read any articles and look at data, you always got to remember there's something called bias. So if you're trying to present a point, you're going to report the data that helps support the point that you want.
Right.
So
right.
everything that's going on isn't what's going to be reported. So they're going to report the good results.
Right.
And they're going to dismiss the ones that don't support the, like if they have a statement they want to make, like this treatment helps 80% of people. So the 20% that didn't help, they ignore that. They just kind of throw that under there, or they'll say 100%. That's because they threw out the ones that it didn't support whatever their statement was. So you always got to be careful. Everybody needs to be careful whenever you read articles or read reports or these studies show whatever, because scientists are known to do this. They'll throw out the data that, disqualifies or doesn't support what they want to report. They'll throw out that part and only report the part that supports what they want to say.
Wow. Wow, it's been very powerful tonight. Just some really great information. Just thank you so much for coming on. Is there anything else you want to share with us tonight, Dr.
No,
Gooch?
I think other than I love coming on this podcast and I love sharing information, because I think anyone who knows me knows that the best way to make me cringe and upset me is to tell me that a man, and everybody knows me, knows this, tell me a man died of prostate cancer.
Wow.
Because, I'm a radiation oncologist. I treat cancer. That's all I do. I treat cancer all day. Not just prostate. I treat all kinds: breast, colon, lung, prostate, you name it, everything from head to toe.
Right.
And it's the only type of cancer that if a man gets to me soon enough, I can cure him.
Wow.
Okay. So if you tell me a man dies of prostate, and people will just watch me flinch.
Wow.
Because to me, that was an avoidable death.
Wow. Men, make sure you getting screened. You just heard it from Dr. Gooch. I mean, if you can get screened, she gave us some very vital information. Get checked, get screened. It could save your life.
It will save your life. And trust me, I go to support groups, and the heartbreak in these women's faces. Remember your loved ones, your wives, your girlfriends, your mothers, your children. They are traumatized. They are absolutely traumatized. And then when I give them these kind of statistics that you could have been cured, I think that's the worst part about it. Like, what?
Yeah,
you mean my husband
sure.
could still be here? What? You mean my father could still be here? You could tell it's almost like they want to get up and walk out. Not that, it's just that the cure rate is so high.
Wow.
It has the highest cure rate of any cancer I treat.
Wow.
It has had the highest cure rate for any cancer we treat. I actually have graphs to show the actual cure rate since the 1930s for prostate cancer. It has the highest cure rate.
That's powerful. Wow. The highest cure rate, but it's killing a lot of black men. We have to change that narrative.
It's the number 2 cause of death for black men. Number 1 is lung cancer. Number 2 is prostate.
Wow.
Number 2. With
Well,
the highest cure rate of all cancers.
Wow. Some great stuff tonight. Just really, once again, very appreciative and grateful for you coming on. I know you're very busy. So I'm just, once again, thankful that you come on once a month to share your knowledge, your skill, and just great information that we can grasp hold of, and hopefully we can get this information and we can live. And that's this podcast.
That's important. So you can live. As I tell men, I want you to walk your daughter down the aisle. I want you to see your grandbaby. And trust me, they want to. They want you here, and they want you to be able to hold your grandbaby. So we can take care of that, DD. We can take care of that.
Yeah, there's a lot of things can deal with that. So
we got a lot of tools in our toolbox for that. We got plenty of tools in our toolbox.
we we can bring back resuscitation. So
That's right. We got
don't
lots of tools. Lots of tools in the toolbox. But remember, get the medicine before you start treatment.
There you go. Get the medicine before you start your treatment. Listen,
That's right.
it's been a great conversation. Thank you again, Dr. Gooch, for coming on tonight.
My pleasure. Thank you for having me. I always enjoy this.
Thank you. Keeping it real with Dr. Gooch on the Advanced in the Kingdom podcast. Listen, I am Matt Tillery. If you're on Facebook, I would greatly appreciate it if you could go ahead and share and like and share. And if you're over on YouTube, go ahead and subscribe to the ML Tillery Outreach. I would greatly appreciate that as well. Listen, tonight, Keeping It Real with Dr. Gooch. Dr. Denise Gooch has been a fantastic night. Until next Monday night at 7 p.m., go and advance the kingdom. Thank you so much for coming on.